Brilliant, thank you. Hello there, welcome to Report Out. It is always my favourite part of the week. I kind of leave Friday with a bit of a skip in my steps. I'm really looking forward to this. So hi, I'm Natasha, I'm the KPO lead and I'll be hosting today. We've got one, possibly two people on the agenda. Andrea has confirmed, but then she has an out of office on. So if we hear from her, brilliant. If not, we'll have to bring her back at a later date. But in the interest of keeping us to time and maybe getting us out even a little bit earlier, I'm going to hand over to Sarah to talk to us about her project.
So hello, good morning, well, good afternoon. Thank you very much for listening to me talk today. My name is Sarah. I am a consultant paediatric anaesthetist based in the Children's Hospital, and I also work for NHS England as a clinical lead for the digital clinical safety team. I'd like to talk to you today about a project I've been doing using the LIM methodology, looking at how we can identify and treat perioperative anaemia when it's been diagnosed in major elective paediatric orthopaedic surgery. Quite long. Next slide, please. So what is kind of anaemia? What is the problem? What is the challenge? So we as an organisation do a lot of quaternary, tertiary work, especially with our orthopaedic patients. And furthermore, a lot of these patients who are having major surgery have complex medical needs. So the diagnosis of anaemia for them is not that uncommon and not that surprising. We didn't have a clear standardized process about how we could identify anaemia and also the treatment for it. And what we know from looking at the evidence base is that having untreated anaemia increases your surgical complications, increases the risk of blood transfusion, increases the risk of length of stay, and generally just has much poorer outcomes. And the treatment of anaemia is something that can be easily done within the community with oral iron tablets. So it's cheap and it's also acceptable to patients as well. So there's a real easy, quick win fix for anaemia, but we just didn't have a good process for identifying it and treating it. Next, can you press the next? Yeah. So looking at the seven commitments, press next again. You can see actually how this project aligns with quite a few of the things that we're trying to do. So when we're thinking about patient-centered care, about the cost, because I mean, on-the-day cancellation is significant cost, especially when it's associated with inpatient beds, and about the increased risk of complications. But I think fundamentally, we're quite behind what our colleagues are doing nationally. Next slide, please. So when we look at the national benchmarking, a national audit that was done in 22-23 showed that 75% of patients were going through their pre-op service and 90% were having a blood count done preoperatively. Whereas for us, actually only 50% of patients were having bloods ordered. And of the ones who were identified as having iron deficiency anemia, that we were not giving any oral iron. So we know that this was an area of significant need of where we needed to improve our service. Next slide. So what do we need to do? So the first kind of thing we had to look at was what is the actual problems and the barriers for change. So looking at the 5 whys, looking at waste and how we can adapt, and using the Tim Woods and the 5S. So a lot of this is more about process. It's not about, you know, the actual physical things that we have within the pre-op service. It's about actually how do we work with the services we've got and the staff that we want. And then finally, just looking at PDSA methods and how we can do small changes so that we can make sure that what we're doing is measurable, and we can also make sure that it's effective. Next slide, please. And just to give a little bit of a background as well to what we kind of discovered when we started exploring this. In regards to orthopaedic surgery, we've got, 83 days on average of the decision to surgery to the date of surgery. Blood's only being ordered 2 weeks beforehand and the pre-op assessment only having 6 days beforehand. So it meant that we had no time if there was any abnormal results to actually treat any anemia. So we've had to think not only about the process of what to do with an abnormal blood result, but also how do we make sure that we can identify the anemia early. Next slide, please. So one of the main things that we've done is look at the kind of which areas of need. So when we started this project, we looked at all of the surgical specialities to see, is this a recurring problem across general, neuro, all the specialities that we cover within the Children's Hospital. And actually what we discovered was that orthopaedic seems to be the main one. So it was made as a consensus agreement amongst the MDT that actually we should focus on orthopaedics. And then if there's any other specialities that need this input afterwards, it's something we can extrapolate out to. But for us, from a kind of LIM, lean methodology wise, made sure that we were really clear and precise and smart from the start. We've worked really well as an MDT, so not just working with kind of clinical staff, but also working with business managers as well to make sure that we can implement this for a new pathway. And our pathway now has got multiple aspects, but essentially, we've now got a way of identifying the patients requiring bloods earlier. We've got a clear pathway for what to do abnormal bloods, and we've also improved the communication to the GP, which is really important because long-term anaemia has neurodevelopmental associated delays. So we need to make sure that we've got all these loops going. Next slide. So what went well? So I think we've managed to highlight an area of urgent need and the potential consequences, and we've managed to make a template for further improvements. This is the first kind of project we've done within pre-op, and what I'm hoping is that it's going to be the template so we can use this methodology for improving other processes within our service. We've improved the guidance and made it so it's really easily for someone to pick it up from the shelf. So if someone goes off on sick, someone else can pick it up quite easily, which is something I'm quite passionate about. And hopefully it means we can start delivering better care for our patients. So this is something that will be re-audited again in the future. Next slide. So what would I do differently? So one of the challenges that I found with this work was about challenging the status quo and about challenging how people work within their settings and making people, and how do you influence someone to change so that they can work within changing how they work day to day. So that's been a big learning point for me personally, but also I'm hoping that this is the first one we've done in pre-op, that will make it easier for other subsequent projects as well. One of the other big things I've learned about is about working with the business managers earlier. So not just working with the clinicians, but also working with the whole MDT a bit earlier, and potentially using task and finish groups more effectively so we can get this work done a bit faster. Can you click next? And I think one of the things which would be a good outcome for this, which we've not done yet, but we should implement within our service, is an improvement board. So looking at the metrics that we've been getting, looking about actually how it's been working, how it's implemented, and using that to make those iterative changes using the kind of key principles of like the PDSA. Thank you. I think that's it. Yeah, thank you.
So I'll give I've got a couple of questions I've jotted down, but I'll open it up to the rest of the group. First of all, does anybody have any comments or questions that they want to ask Sarah? No? Okay.
That's a good sign.
Thanks for taking the slides down. No, I can see your lovely face as well, which is better. So I have a couple of questions. My first one was around, I know you said you're going to re-audit things from that second slide that you said, but have you already observed any reduction in on-the-day cancellations or reduction in length of stay because of this optimization beforehand? Have you got any sense of that?
Yeah.
No.
Not yet, not with clear metrics, because we're still in the kind of implementation stage of getting the pathways approved. So we're still going through the corporate governance. But I think but what I've noticed from doing my pre-op sessions is we're getting a lot more referrals from the orthopaedic surgeons and also from the nurses about what to do with abnormal blood results. So I've kind of objectively noticed that we're getting more blood results through. And also knowing that we're all prescribing iron is like an improvement from, what we had previously, when no iron was prescribed for 6 months. So this is something that will be re-audited probably. So one of the joys about being on Teams, you can't see that I'm actually 38 weeks pregnant. So when I come back from mat leave, it's something I'll be re-auditing. So hopefully it's given enough time to bed down and settle and actually see what's working and what's not. And I've also got one of the future leader program new future leaders, fellows working with me on this work as well. So she's kind of taking the leads on implementation when I'm gone. But yes, I think objectively, I've noticed there's been a change in practice since we've started discussing this pathway work from the nursing point of view and from the orthopaedic point of view, and also from our point of view. But I think a reaudit in about a year will actually be very helpful in just actually cementing, has this really made a difference?
Yeah, and I'm sure it will. I mean, we might not be able to see the outcome, but we can measure those changes in process and that iron prescriptions and all of those things. So I'm sure there will be a lot of impact there. And then my second one, is around scaling it up and spreading it. If this is really successful, you mentioned you narrowed your focus down into ortho.
Yeah.
Have you got a sense of other places that might benefit from this or having a look at it? Who else was on your list
So we looked.
originally?
So we had a look at the other surgical specialities, talking to the clinical leads about if they thought that this was kind of an area of need for them, and what we kind of, and it's unusual for the major surgery, things like spines and neuro, to go through the process without having bloods done. So normally kind of anemia is picked up from their other pre-op investigations. One of the nice things which has come out from this piece of work is the generic guidance about how to treat anemia. So if the patient is identified with having anemia, then it's been done with us, pharmacy and paediatric hematology. So it's quite clear about what drugs to give. So there's a lot of things which come out of this which are generic. So even though the specific pathway is about orthopaedics, there are other things, there are other specialities which can take on what we've done.
Oh, that's brilliant. Right. Oh, we've got a hand up from Tom.
So sorry, I don't know why my camera's not working. I'm gonna have to do a computer reset. But this all sounds really exciting, Sarah, because I'm doing some work with within the women's CSU with regards to screening mothers for anemia much sooner, and again trying to look at those sort of balance measures of not having to use infusions and things further down the line. I'd be super keen to hear about the successes you're having within that governance process around bloods and things, to see if there's anything that we could look at with within that particular process as well, and if there's anything that'd be transferable.
Yeah, I absolutely agree. And I think it's really exciting doing it in the maternal CSU because the with my other hat on NHS England with the infected blood inquiry, and this is going to be a big tidal wave for all organisations to report about how they manage anemia in the future. And it's such, like you say, it's such a quick fix. It's such if you can treat with oral iron before you have to give IV, it's better for the patients. And especially iron infusions in pregnancy aren't that safe. So, if you can treat with oral, it's so much better. So yeah, it would be wonderful to discuss that in the future. And like I say, because I've got my NHS England hat on, I can help you with that as well. Because I do lots of work with the blood transfusion
I might touch
service.
base with you afterwards if that's okay. I'll send you a message.
Perfect.
So, yeah. Thank you.
Fabulous. Just any more for any more? Oh, go on then, Katie.
Thanks. Thanks, Sarah. And just wanted to ask, improvement can be quite difficult. Making change can be quite difficult. Do you have any tips you've done? You've managed to create a pathway across multiple stakeholders with different priorities and views and things. Have you got any tips for people trying to make improvement that might help them?
I think my two kind of learning points was, my learning points about trying to keep the momentum. So I think one of the things which I'll be a little bit more focused on next time is about having that real clear task and finish group and that real clear timelines of this is what we need to have things done for. I think that's one thing. And I think working with the business managers earlier is much, because they've got better understanding of the organization, how it works and the different levers. Like, for instance, if I spoke to you guys earlier, I might have found out that Tom was doing this in maternity. So, those kind of cross-linking would be useful as well. But the interesting thing about this piece of work was the actual drive for change was the cases being cancelled. And that was the reason why people started to actually engage with the work a little bit more when it started to have natural consequences for them as well, which is frustrating as when you're trying to push something forward that you have to wait for something like that to happen. But unfortunately, that's the nature of human behavior. So sometimes it's just kind of, you can push things as much as you can, but then sometimes you just got to wait for something to happen and then suddenly it all can fall into place. So they're my learning points.
Right. So persistence and visibility of data and networking, those are kind of quite interchangeable things. Yeah. Thank you.
Thanks.
Yeah, it was fabulous. And I'm really sure that we'll see a lot of the impact and the cancellations, the outcomes really, really soon. And I don't think there's anything else to say other than congratulations and enjoy your maternity leave.
Oh, I can't wait.
Yeah. And thank you so much. It was brilliant. We can't wait to have you back as well.
Thanks.
All right. Okay. Thank you. All right. We'll see you all soon. Bye.